So in the athletic population, and in any population dealing with a meniscus tear, there are three main classifications of meniscal tears. As you can see on the left, there's the longitudinal, in the middle there's the radial, and on the right there's the horizontal tear. And then beneath, on the bottom row, are the progressions of the meniscus tears if there's not a surgical intervention done, or the the tear has just been ignored and hasn't been taken care of or been managing the symptoms. So the longitudinal can progress to a bucket handle tear, which is a pretty massive tear and causes a lot of pain. The radial tear leads to the parrot beak, and the horizontal can lead to a flap tear. And the onset of these injuries can be either chronic or acute. Mainly in the athletic populations, we see the acute injury, such as Adrian Peterson here on the right. Um, and this normally happens with quick changes of direction or as a concomitant injury, which happens along with the ACL tear in the unhappy triad, which includes ACL, the MCL, and the medial meniscus. Um, Chronic tears usually happen over time, and it tends to happen in the older, less active population where there's just been years and years of chronic repeated um, force put on that meniscus, which causes some degeneration, which can lead to a tear. During the operative techniques, um, there are usually two techniques performed. Um, Meniscectomies, which are usually performed in the white or the pink vascular zones, um, and in the more vascular zones, such as the red zone, um, there's usually repairs with a suture. Usually repairs with sutures are done because of the high blood flow to that area, which will help heal that tissue back together. And the meniscectomies are done in the white zones because there's not as much blood flow, so suturing might not work, and doctors do not want to perform or sutures in the white zone just in case it doesn't take, and then they have to perform the meniscectomy. That will put the patient through two operations, and it can set their rehabilitation and their return to activity back quite some time. When you look at return to play rates, they're relatively high. Players such as Adrian Peterson has returned to play this season after sustaining a season-ending meniscus tear injury last year. Um, so in surgical interventions, a majority of athletes return to play, over 60%, which is pretty good, and 18% even return without a surgical intervention. And sometimes with return to play rates, because of the possibility of an ACL or MCL injury as well, return to play might be delayed so that they can complete the rehabilitation for those other injuries. When it comes to clinical relevance, what is the best approach to take with a meniscus injury? From the literature, it really comes down to the location of the tear. It also comes down to the severity and the area of the meniscus that the tear takes up, and the pain level of the patient. With the pain level, um, it can their pain level can influence how much activity they're able to do and how they're able to modify their activity, as well as completion of rehabilitation. From the literature, the gold standard is surgery to perform either a meniscectomy or a repair with sutures, but they can patients can also return to activity with uh, with modifications as long as they're performing constant rehabilitation to manage their symptoms and their pain. And with that being said, are there any other questions about this research? Thank you for your time. Have a good night.